Hi everyone. So we are live here and we'll be talking about the must know topics for pediatrics. Everyone. So what we'll do is I'll be talking about the most important topics for your exams and we will be classifying your topics into systemic pediatrics and general pediatrics. So is everyone there? Can you give me a hi on the chat box? So what we'll do is we'll first of all talk about important topics from cardiology. And in cardiology, what we'll do is first of all we'll talk about okay, let's first before taking cardiology, let's take CNS first. Okay. So in CNS, you will be asked multiple specific epilepsy syndromes. And the first epilepsy syndrome in CNS, which we'll be talking about, is called infantile spasms. Remember infantile spasms? These children present to you like salam seizures. They present like salam. So it's bilateral, flexor, symmetrical contractions. Okay, so they are bilateral, symmetrical, flexor contractions. So remember they are mostly flexor and they occur in infants. So it is common between 4 to 8 months of life. So you may get a patient, you may get a clinical history, and in your AIMS exam, you may even get a video. Okay. Now remember the EEG in infantile spasms is very classic. The EEG classically shows hips arrhythmia. So all of you please have a careful look at this EEG. This is called hips arrhythmia. What is this? You can see it's generalized. So whenever you see a EEG, please whether it's generalized or focal. So on your screen is a generalized chaos. It's a generalized chaotic pattern of slow waves. Generalized chaotic pattern of slow high voltage waves. So this is hips arrhythmia and this is classic of infantile spasms. Okay. Now remember the drug of choice for infantile spasms is ACTH. So remember the pathogenesis of infantile spasms is that it occurs via CRH. So it occurs via CRH. Okay. So the drug of choice is ACTH to inhibit the CRH. Now please remember that infantile spasms can be caused by HIE. So they can be secondary to HIE. But remember they can be seen in multiple other disorders like Down syndrome. Remember babies with Downs during infancy they have infantile spasms. So especially for babies with tuberous sclerosis. So remember for infantile spasms, for babies with tuberous sclerosis, the drug of choice is vigabatrin. Okay. So for babies with tuberous sclerosis, the drug of choice for infantile spasms is vigabatrin. Otherwise, we always give ACTH in these babies. Okay. Now remember what is West syndrome? Someone in the class today is asking me what is West. So remember West syndrome is a triad. So remember West syndrome is a triad of infantile spasms, developmental delay or developmental regression. Okay, so it's a triad of infantile spasms, developmental delay or regression, and hips arrhythmia on the EEG. Okay, and hips arrhythmia on the EEG. Okay, so that's West syndrome. So remember, infantile spasms is not West syndrome. West syndrome is a triad of infantile spasms, developmental regression, and hips arrhythmia on the EEG. Okay, so remember that. Now in your exam, you may be shown or you may be given a clinical case of a child who gives you a classic vacant stare lasting less than 30 seconds. It's a common case which comes in every exam of absence seizure. So in absence seizure, remember, you get a vacant stare or a blank stare lasting less than 30 seconds. Okay, lasting less than 30 seconds. There is no aura, there is no postictal phase, so there is no aura, there is no postictal unconsciousness or no postictal drowsiness, so there is no phase of postictal, and remember there is a vacant stare. Now the EEG, it's a very common EEG which comes in your exam, and all of you, can you see every second? It's a generalized spike and wave pattern on your screen. So you can see on your screen a generalized, so you can see it all over the brain. Okay, okay, so you can see all over the brain, generalized 3 Hertz spike and wave pattern. That's classic of absence seizure. Generalized 3 Hertz spike and wave pattern is classic of absence seizure. Okay, and please remember the drug of choice for absence seizures, the drug of choice is ethosuximide. It's not valproate, it's ethosuximide, because there have been a lot of studies on this, there have been a lot of randomized trials, and they all say that the side effects of ethosuximide are less as compared to valproate. So remember, ethosuximide is safe as compared to valproate. So your first drug of choice for absence seizure should be ethosuximide. Okay? Okay, all of you? Now let's go further. And all of you, the next and the most important epilepsy for your exam, if you ask me which is the most important epilepsy syndrome for your exam, that will be definitely juvenile myoclonic epilepsy. Juvenile myoclonic epilepsy, which is also called the Jan syndrome. It's also called the Jan syndrome. Okay? Now remember that this is the most common generalized epilepsy syndrome in young adolescents. So remember, this is the most common epilepsy syndrome in adolescents and young adults. Okay? Adolescents and young adults. Remember, in your last exam, in fact, they asked what is the inheritance of juvenile myoclonic epilepsy. Remember, it has a polygenic inheritance. What do I mean by polygenic inheritance? By polygenic inheritance, I mean that there are many genes involved, and if you have mutation in multiple genes, it has an additive effect on the clinical presentation. Okay, so suppose you have mutation in 2 genes, then the patient will have more manifestations. So it has a polygenic inheritance, and the gene is mostly on 6p. So one of the locus, the most common locus for JME is on the short arm of 6 chromosome. Okay, now remember that one of the gene is GABRA1. There are many genes, but in a recent AIMS exam they asked you about the GABRA1 gene. So one of the GABRA1 gene, there are many genes. Okay, there's a query here by a student. So remember, this is just one of the gene implicated, but there are many genes involved, which you cannot remember the names of all of those 10 genes. Now remember that initially these young adolescents, they just have myoclonic jerks in the morning. So they present typically with myoclonic jerks in the morning. They drop things in the morning, and later 90% of them present with GTCS. So remember, usually they present to the doctor with GTCS. So remember, they present to the doctor with GTCS. That's how they present to the doctor. Remember, 1/3 of them can also have absence seizure. 1/3 of them can also have absence seizure. Okay? But remember, most of them will come to you with a GTCS. Now, EEG is classic for juvenile myoclonic epilepsy. EEG is classic. And what do you see in EEG? Remember, what you can see here on the screen is a polyspike. So there's a spike and wave, spike and wave. So the typical EEG in JME is a generalized, you can see spikes and then waves. So it's a 4 to 6 hertz. मैंने कहा absent seizure में था 3 hertz. But in JME, okay, you have 4 to 6 hertz. Polyspike and wave pattern. Okay, so what is the classic JME EEG? It's a 4 to 6 hertz polyspike and wave pattern. Okay, so remember that. Now, what is the drug of choice for JME? And all of you, in every NEET-PG, this question definitely comes. And this question came in last year's NEET-PG also. I'll tell you the exact question. For that, I will show you the exact sentence from the Nelson's textbook. So all of you, we follow Nelson's textbook. The current issue is 21st edition. And all of you, read with me slowly and carefully. The drug of choice for JME is valproate, lifelong valproate. Okay? Drug of choice is lifelong valproate. But if there is a concern for hormonal and fetal side effects, the drug of choice for JME is levetiracetam. This question came in your NEET-PG exam. So question was, if there is a concern for hormonal and fetal side effects, the drug of choice will be levetiracetam. Okay? Okay, all of you? So remember that. Now, the other drugs which can be used in JME are lamotrigine, zonisamide, topiramate, and perampanel. Okay, so these drugs can also be used in JME. I will again repeat for you: lamotrigine, zonisamide, topiramate, and perampanel. Remember, the drugs which are contraindicated in JME are phenytoin, carbamazepine, so CBZ matlab carbamazepine, and oxcarbamazepine. Remember, even gabapentin is also contraindicated in JME. Okay? So all of you, let us read this together, very important. The drug of choice for focal seizures is oxcarbamazepine in children. Okay? So drug of choice for focal seizures is oxcarbamazepine in children. For absence seizure, ethosuximide. For absence seizure, drug of choice is ethosuximide. And for generalized seizure, so someone, if they ask you, what is a drug of choice for generalized epilepsy in children? So then you should say levetiracetam. So drug of choice for generalized epilepsy in children is levetiracetam. Okay? So please remember that. Okay? Also remember what are the drugs which are contraindicated in EEG, especially in a case of JME. And all of you, please also note this down, that JME can be provoked by photic stimulation. So हमने इसकी आंखों पे टॉर्च डाली and it can be provoked by photic stimulation. Okay, so all of you please remember this, that like for absence seizure I said drug of choice is ethosuximide. Now hyperventilation provokes absence seizures, but photic stimulation provokes JME. These jerks, these myoclonic jerks are provoked by photic stimulation. Okay, okay, can we go further? Let's go further. So now what I'll do is I'll take you to important topic in congenital heart disease. And first of all, remember that the most common congenital heart disease is a VSD. Most common congenital heart disease is a VSD. So almost 30 to 35% of all congenital heart disease is a VSD. Now if they ask you which is the most common cyanotic heart disease, remember tetralogy of Fallot is overall the most common cyanotic heart disease. Okay, tetralogy of Fallot is the most common cyanotic heart disease in children. Now if they ask you which is the most common cyanotic heart disease in a newborn, the most common cyanotic heart disease in a newborn will be transposition of great arteries. Okay, so remember transposition TGA is the most common cyanotic heart disease in a newborn. So remember that. And let us talk about tetralogy of Fallot, the most common cyanotic heart disease. Tetralogy of Fallot. So remember there are 4 things in tetralogy of Fallot. So what is this tetralogy? What is TOF all about? So there are 4 things, 4 components. Valvular pulmonary stenosis. It's a valvular. Most commonly, it's more of a subvalvular infundibular. So remember, in tetralogy of Fallot, infundibular, which is more of a subvalvular variety, is more common. Okay, so infundibular pulmonary stenosis, which leads to right ventricular hypertrophy. Aorta is overriding the VSD. Aorta is overriding the VSD, the ventricular septum. Okay, so remember aorta is overriding the ventricular septum, and yes, one of the student has correctly mentioned you have a perimembranous VSD. So you have a perimembranous VSD. Now, which is the most important component of TOF? Now this is what your examiners will somehow lead you to this. The most important component of TOF is pulmonary stenosis. Now because of the pulmonary stenosis, remember because of the pulmonary stenosis, the right ventricular pressure increases. Okay, the right ventricular pressure increases, and now because the right ventricular pressure increases, there is a right to left shunt. So suppose I make a heart for you like this here. Suppose this is your heart and this is the left and the right, and here is the pulmonary stenosis. Now because of the pulmonary stenosis, the right ventricular pressure increases so much that it becomes suprasystemic and the shunt becomes right to left. So remember all of you, the most important component of tetralogy of Fallot is pulmonary stenosis. And tetralogy of Fallot presents after the first year of life. Why it presents after the first year of life? Because what happens after first year? As they grow, the pulmonary stenosis severity increases with age, and the right to left shunt increases with age. Okay, so please remember this. Now, very commonly in NEET-PG, they ask you about the chest X-ray of tetralogy of Fallot. Remember, it's a typical boot shaped heart, which is called coherence abort. It's a typical boot shaped heart called coherence abort. And in fact, in the last 2 years back in the NEET-PG, they asked, why do you see a boot in TOF? So we see a boot in TOF because of the right ventricular hypertrophy. So on your screen, can you see the uplifted apex? This uplifted apex is because of right ventricular hypertrophy. So remember, this boot shaped heart is basically the uplifting of apex because of RVH. Okay. Now remember, your examiners will really like to ask you about cyanotic spells. So all of you should know why we have cyanotic spells, how do we treat cyanotic spells, what do you see clinically in cyanotic spells in tetralogy of Fallot. So remember, tetralogy of Fallot, I said we have a query here. It's common after the first year of life. Okay. Now during the time of the cyanotic spell, the right to left shunt increases. Okay. Because of which there is hypoxia, because of which the respiratory center is stimulated. Okay. Because of which respiratory center is stimulated. Now there are three pathogenesis. Remember, there are three pathogenesis of cyanotic spells. Number one, the systemic vascular resistance falls. So suddenly there is a reduced systemic vascular resistance and right to left goes easily. And the secondly, there is a dynamic pulmonary stenosis. And thirdly, this baby is crying. Crying also aggravates because whenever you cry, there is increased venous return and there is increased right to left shunt. Okay. Now before I go further, all of you, I want to tell you a very important point. Remember, the murmur in tetralogy of Fallot is because of pulmonary stenosis. This murmur is because of pulmonary stenosis. Okay. It's because of the blood going through the pulmonary valve. Now, if there is a spell, this murmur on the left second intercostal space, during the spell, it's right to left across the ventricle. Less blood is going to the lungs. So during the spell, the murmur disappears. Please remember this, keep it in your mind. During the spell, this baby is breathless. You can see here, he's breathless. He's crying. And the murmur disappears. Okay. Now remember that to reduce, since this baby has oxygen is less, we will give him oxygen. We'll give him intravenous sodium bicarbonate because he is acidotic. To treat this respiratory center, we'll give him subcutaneous morphine. To treat the dynamic pulmonary stenosis, we'll give him intravenous propranolol. So remember, intravenous propranolol is because of the dynamic pulmonary stenosis. So, it reduces the PS. And lastly, to increase, now SVR has reduced. So to increase the SVR, we'll keep him in a knee chest position. We'll keep this child in a knee chest position. We'll give him drugs which increase the systemic vascular resistance. For example, intravenous ketamine and intravenous phenylephrine. For example, intravenous ketamine and intravenous phenylephrine. Okay. So remember that. So this is the masala for spell. Now if a baby has recurrent spells, he needs a surgery. So remember, in tetralogy, if there are recurrent spells, we go for a palliative shunt. And remember the classic palliative shunt here on your screen, you can see it's called a Blalock-Taussig shunt, where we anasmose the subclavin to the pulmonary artery. So here we anasmose the subclavin to the pulmonary artery. Okay. So that's called the classic Blalock-Taussig shunt. And in the modified shunt, actually, all of you, can you see we are inserting a tube here. A Gore-Tex tube is inserted between the subclavin and the pulmonary artery. So nowadays we all do a modified Blalock-Taussig shunt if a baby has recurrent spells. Remember, they may also ask you about TGA. TGA is the most common cyanotic heart disease in a newborn. TGA matlab transposition of great arteries. Someone was asking here, it's transposition of the great arteries. And on your screen, you can see a classic X-ray of TGA. What can you see here on your screen? Anda, egg on side. So you can see an egg on side appearance in a case of transposition of great arteries. Okay. So transposition of great arteries, remember they have a narrow waist on the X-ray and it looks like an egg below. Now because of the transposition, what is happening here is, superior vena cava joins the right side, inferior vena cava joins the right side. These are the pulmonary veins. Now in transposition, what is happening here is that now aorta arises from the right and pulmonary artery arises from the left. So the impure blood, students, the impure blood is going back to the systemics. Impure blood goes back to the systemic. So there is a systemic unoxygenated blood and the pure blood goes back to the lungs. So the pulmonary oxygenated circuit. So TGA has two parallel circuits. Okay. So there are two parallel circuits, systemic unoxygenated and pulmonary oxygenated. So remember all of you, you may get a question in your exam that this baby is born cyanotic. A baby who has complete TGA, no communications, is born cyanotic. So what will you do in the middle of the night? You need mixing. So the emergency surgery, before that you should start mixing by prostaglandin infusion. So in case of TGA, in the middle of the night, you should start him on prostaglandin infusion. Okay? And after that, in the middle of the night, you open the atrial septa. Atrial septa ko tod do with a balloon. So in the middle of the night, there is an emergency surgery called Rashkind balloon atrial septostomy. Rashkind balloon atrial septostomy. So this is done in the middle of the night. In case of a TGA, हमने balloon से atrial septum को तोड़ दिया, मतलब more mixing, more oxygenation. And the definitive surgery is done within the first 2 weeks of life. So definitive surgery is done within the first 2 weeks of life, which is called switching the arteries. It's called a Jatine's arterial switch. So we switch the arteries within the first 2 weeks of life. So as soon as possible, within the first 2 weeks of life, we switch the arteries in transposition of great arteries, especially children who come to us with cyanosis within the first week. So a child, if he comes with cyanosis, we will, we should do this. Okay. That's how our life is. There's a query here, sir, why in the middle of the night? Because that's how our life is. All the emergencies happen in the middle of the night. And yeah, so once you become a PG, you'll realize what happens. So now we'll be taking you to acquired heart disease. And on your screen is a very, very important topic, especially in the COVID era. Kawasaki disease. Kawasaki disease, remember, is the most common acquired heart disease in children in the developed world. It's the most common acquired heart disease in children in the developed world, in America, Japan, and Chandigarh, like I told you in all of your classes. So remember, it's the most common acquired heart disease, especially in the developed world. Okay? Especially in America, Japan, and Chandigarh. Okay? Especially in America, Japan, and Chandigarh. Okay? And why are we talking about Dr. Kawasaki? Because it's important in the COVID era. And also Dr. Kawasaki, he left us in June last year in the COVID era. He died in June 2020. So may he rest in peace. And what we'll do is, we'll be talking about that in your exam, you will definitely get a case with these features. And all of you please look at this, because way back in 1967, Dr. Kawasaki made this diagram with his pencil. So Kawasaki disease has three phases: acute, subacute, and convalescent phase. And as you can see, first 10 days is the acute phase. First 10 days is the acute phase, when a child gets fever, arthritis, thrombocytosis, fever, arthritis, thrombocytosis, myocarditis, swollen palms and soles. So, mucosal involvement is seen in the acute phase. Now, why am I talking about this? Because in your exam, they will ask you, what is the most common cause of death in the acute phase of Kawasaki? The most common cause of death in the acute phase of Kawasaki is the myocarditis. And students, yes, COVID in children resembles Kawasaki. Last year has been, a spurt of Kawasaki disease. Every pediatrician has seen so many Kawasaki's last year, I cannot tell you. Okay, I'll talk about that in a while. Hold on. Okay, so the most common cause of death in the acute phase of Kawasaki is myocarditis. Aneurysms appear late, students. They occur usually in the second to third week of illness. मैं फिर से बोलता हूं, the most common cause of death in the acute phase of Kawasaki is myocarditis. But overall, what is the most common cause of death in Kawasaki? Coronary artery aneurysms. Coronary artery aneurysms. Okay, and also please appreciate here that the desquamation of the palms and soles is also seen in the second to third week of illness. Your examiners love this question. So desquamation is also seen late. Okay, so overall, yes, aneurysms, okay, is the cause of death. And on your screen, this is what your examiner is looking at. He will show you a coronary angiography in a child. And on your screen is a coronary angiography showing aneurysms. Remember, 20 to 25% of children who get Kawasaki disease get aneurysms. 20 to 25% of children with Kawasaki get coronary artery aneurysm. Okay, they get coronary artery aneurysm, matlab thrombus in the coronary, matlab sudden death. Students, all of you, wondered, it's been 2 years, Sri Devi died, and I told you in your classes that I think that Sri Devi died of Kawasaki disease. When she was a baby, she had, just fever, rash, lymph nodes. No one cared about that. They said, viral illness. And she got aneurysms. And then suddenly they die. So remember, 20 to 25% of patients with Kawasaki disease get coronary artery aneurysms. Okay, so all of you have to know this. Okay, you cannot pass without this must know topic of Kawasaki disease, because this is how we have been working since last 1 year. So what is in our mind in the last 1 year? Is it Kawasaki or not? We used to talk this in the ICU every day. So most important criteria for Kawasaki is fever more than 5 days. Fever more than 5 days. Okay? Okay, remember that. And changes in the extremities like acute changes. So you need to have fever at least 5 days with at least four of these 5 criteria. Okay, and I have told you in your classes multiple times, changes in the extremities, erythema, okay, of palms and soles. Now in the subacute phase, remember it's very specific. Second to third week of illness, you see peeling, a rash, bilateral conjunctivitis without exudates, changes in the lips and oral cavity like strawberry tongue, involvement of the oral mucosa, and cervical lymph node is mostly unilateral. Okay, it's mostly unilateral, more than 1.5 centimeters. So please remember this. Okay, now why are we talking about this today? Because the drug of choice for Kawasaki is intravenous immunoglobulin 2 grams per kg. So you have to give in the acute phase, students. We have a query here. So remember, you have to give it only in the acute phase, which is the first 10 days of illness. Otherwise, you cannot prevent aneurysms. And you have to give it within the acute phase. And now the risk reduces to 4 to 6%. So now the risk, if you give IVIG in the acute phase, the risk reduces to 4 to 6%. Okay. Along with that, you have to give aspirin around 100 milligram per kg per day. So you have to give aspirin 100 milligrams per kg per day of aspirin, okay, for 2 weeks. So we give anti-inflammatory dose of aspirin for 2 weeks. Okay. So remember this. Now why all of you will be asking me, sir, Aj, what have you seen in the last year in children with COVID? Students, last year when COVID was rampant, it's still rampant. When I still did clinics, and in my clinics I saw a lot of children with fever, persistent fever, and this curve shows, this is the adult curve, this is the adult curve of COVID. अभी तो adults में COVID हो रहा है in our country, but after 4 to 6 weeks of the peak of adults, we see children with COVID. So children basically get MISC. So coming to COVID students, coming to COVID children get MISC, multisystemic inflammatory syndrome in children with COVID. Multisystemic syndrome in children with COVID. Okay, it's an inflammatory syndrome. So all of you should have an idea about the WHO definition for MISC. So once adult में खत्म हो जाता है, फिर बच्चों में शुरू हो जाता है. इसका मतलब this is more, MISC is more like a delayed cytokine storm, a delayed immune reaction, like a delayed cytokine storm. Now students, all of you read about adults, many of my relatives who had a cytokine storm in the second to third week of COVID. Now children do not get acute problems. They get a latent infection initially, and after 2 to 3 weeks of that infection, they get multi-systemic involvement. It's like akin to the delayed cytokine storm in adults. Okay, all of you, so please remember that. So you need to remember the WHO definition for MISC. So WHO definition for MISC is a child less than 19 years who presents to you with persistent fever. A child less than 19 years who comes to you with fever more than 3 days and 2 of the following. Okay, a child less than 19 years, fever more than 3 days, 2 of the following. Okay, 2 of the following. Just like Kawasaki, rash, mucocutaneous involvement, shock, cardiac involvement. So they may have myocarditis. I have seen many children in North India with myocardial failure in the last year. Many who died because of this. Coagulopathy, acute GI symptoms. plus they have elevated inflammatory markers. Okay, so you need to have two of the system involvement, elevated inflammatory markers like ESR, CRP, procalcitonin. Okay, okay, ESR, CRP, procalcitonin. Okay, all of you. Then, of course, there should be an evidence of COVID-19. There should be an evidence of COVID-19. So, PCR नहीं होता इनमें, mostly PCR नहीं होता, mostly क्या मिलता है? IgG COVID positive. So this is what I saw last year, and हमने खुद सीखा ये बात कि I saw children with persistent fever and सब कुछ कर लिया मैंने, डेंगू, मलेरिया, टाइफाइड, आखिरी में करवाया IgG to COVID, and it was actually a MISC. And why am I talking about MISC? Is because again the drug of choice for MISC is IVIG with aspirin. So drug of choice for MISC in children is IVIG with aspirin. If it fails, we add IV methylprednisolone. If it fails, we give IV methylprednisolone. Okay, if it fails, we give IV methylprednisolone. So we have a criteria, all of you. We follow these criteria. And again, so this is the way we go in children with severe multisystemic COVID. Okay, so as you know, अब जब हमारा देश जब स्कूल शुरू करेगा ना, तो you will see a lot of MISC. Okay, IVIG followed by steroids, followed by many other drugs. In fact, all of you please remember tocilizumab is very important. Tocilizumab is anti-interleukin 6, and there are many other drugs which you can use like anakinra, anti-interleukin 1. Okay, so tocilizumab we have tried a lot. It is anti-interleukin 6. Remember that. Okay, so it suggests all of you please remember end of claps. If you want to remember about COVID, please remember end of claps. This is my mnemonic. You will not find it in any textbook. End of claps. ESR is high. Neutrophilia for MISC. The mnemonic is end of claps. ESR is high. Neutrophilia. Low sodium. Okay. Okay. D dimer is high. There is no other obvious cause for this child's fever and multisystemic involvement. F stands for ferritin is high. C stands for CRP is high. L stands for lymphopenia. ये important है. All of you know in COVID there is lymphopenia. Albumin is low. P stands for the heart pro-BNP is high. Platelets are low. Now please, can you see this? Kawasaki mein platelets were high. In MISC, platelets are mostly low. And the serology, the IgG is positive against COVID virus. Okay. Okay. We are, there's a query, why not in Indians? Of course, all of us, everywhere, everyone in the world is wondering. Of course, MISC is more commonly seen in UK, Hispanics, African Americans. So if you ask me the race, MISC was more commonly seen in Hispanics, African Americans, Italians, French people. So maybe we are not Hispanics and French. That's why. Now, all of you please remember, I said Kawasaki is the most common medium-sized vasculitis in children. Okay? Okay? Medium-sized vasculitis in children. Now, HSP is the most common vasculitis in children. So, please remember HSP is the most common vasculitis in children. So, HSP, which is also called IgA vasculitis. Okay, remember it is the most common vasculitis overall in children. It is the most common small vessel vasculitis. Okay, 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 all of you. So please remember that. It is also the most common leukocytoclastic vasculitis. You know, leukocytoclastic matlab the WBCs are invading the vessel wall. And students, every NEET PG a question comes on HSP, Henoch Schönlein purpura. On your screen you can see palpable non-thrombocytopenic purpura. So these are, palpable. You can palpate them. Non-thrombocytopenic. So platelet count is normal, purpura on the extensors. So please, all of you, please remember the criteria. The criteria are very important of HSP. The criteria are very important. And even last year, we'll talk about last year what happened in the NEET PG. So you need to have two of the following criteria for HSP. Palpable purpura, onset less than 20 years, okay, onset less than 20 years, bowel angina. So ये सबसे important है all of you, the bowel angina. You will have a child with pain abdomen, bloody diarrhea. And students, last year in your NEET PG there was a child with pain abdomen, bloody diarrhea and palpable purpura. So all of you messaged me, sir, bloody diarrhea. Can you see bloody diarrhea in HSP? Yes, bloody diarrhea is a part of HSP because of mesenteric ischemia. It's because of mesenteric ischemia. Okay. So there's a query about COVID. Remember, acute COVID में RT-PCR करते हैं, पर cytokine storm में और MISC में IgG करते हैं. Okay. So remember, you will see biopsy showing leukocytoclastic vasculitis. Okay. Biopsy will show leukocytoclastic vasculitis. Now remember, in your exam, definitely you will find a child who has nephritis, hematuria with hypertension. So remember, HSP nephritis is seen in 50% of cases of HSP. It is seen in 50%. Okay. Okay. And kidney is involved within usually 6 weeks of illness. Kidney in HSP is usually involved within the 6 weeks of illness. Okay, so please remember that. In kidney, you will see microscopic hematuria, microscopic RBCs, plus minus proteinuria. So in kidney, you will see microscope में RBCs on the urine examination plus minus proteinuria. So only in severe HSP we give steroids. So we give steroids only in severe Henoch-Schönlein purpura. Okay, remember that. So that's very important topic. Now remember, one of your favorite of your examiners is, they will ask you about, coming to respiratory system, they will ask you about a child who has fever with stridor. Fever with stridor. Okay, fever with stridor. Now remember, if you have Barkey cough, if you have a Barkey cough with a steeple sign, think about croup. So croup has a viral prodrome, Barkey cough. Now remember, the drug of choice for croup, a favorite of your examiners. So drug of choice for mild croup is a high dose DEXA. It is a high dose DEXA which is 0.6 milligrams per kg. 0.6 milligrams per kg. So drug of choice for mild croup is dexamethasone 0.6 milligrams per kg. Okay. Okay. Now if there is a moderate to severe croup, इसका क्या मतलब है मॉडरेट टू सिवियर? ऑल ऑफ यू स्टूडेंट्स आस्क मी एवरी डे ऑन फेसबुक, sir, what is moderate to severe croup? Now in moderate to severe croup, stridor at rest, retractions, cyanosis, inability to drink. Okay, सिर्फ एक क्राइटेरिया नहीं है, इट्स अ कॉम्बिनेशन. You will be given a story and you have to decipher. So stridor at rest, retractions, cyanosis, inability to drink. Okay, so ऐसा है तो you will add nebulized racemic epinephrine. So if there is a moderate to severe crew, you add nebulized racemic epinephrine. Add nebulized racemic epinephrine. Okay. Now on the other side, students, you may be given a child who comes to you with very severe, on your screen is a thumb sign. It's simple, but still you may have a thumb sign showing epiglottitis. Now students, someone asked me, look, croup is viral, para-influenza. Epiglottitis is bacterial, and all over the world it's streptococci. Streptococcal is the most common cause. In India, H1N1 is more common because we don't have vaccination yet much. So अभी हम H1N1 से vaccinate नहीं कर पाए. COVID तो दूर की बात है. So H1N1, okay, in India. So remember, for epiglottitis, you can see a thumb sign. Airway is a must, followed by a third generation cephalosporin, ceftriaxone. So airway is a must, followed by a third generation cephalosporin, ceftriaxone. Now all of you, in your exams, the next important topic which can come in your exam is a child with shock and ambiguous genitalia. On your screen is not a boy, it's a hypertrophic clitoris. So you may get a child with ambiguous genitalia, okay, with shock, जिसको कहते हैं CAH, congenital adrenal hyperplasia. What is CAH? Remember, it is the most common cause of a female pseudo-hermaphrodite. Okay, it's actually a female, पर देखने में कैसी लगती है? मेल जैसी. Pseudo hermaphrodite. All of these are NEET-PG questions. Most common cause of a female pseudo hermaphrodite. Remember, 90% of CAH is because of deficiency of 21 hydroxylase enzyme. So 90%, adrenal gland में there's a deficiency of this enzyme 21 hydroxylase. So cortisol is not there. So there is low cortisol. So this patient has hypoglycemia. Aldosterone is not there. So if there is low aldosterone, this patient is in shock. Low sodium and high potassium. Hyperkalemia. इसको कहते हैं salt wasting crisis. So these children present to us with salt wasting crisis. Okay? Salt wasting crisis, and they are in hyperkalemia. Okay? Now remember, testosterone is high. So high testosterone is high. So because of that, all of you, females may have hypertrophy of the clitoris. So females, they look like males. Hypertrophy of the clitoris. And because cortisol is not there, you can see the scrotum is pigmented. इसको कहते हैं एम्बिगुअस जेनिटेलिया. I don't know. Labia are pigmented like scrotum. So scrotum are empty. So females actually have ambiguous genitalia. So please note this down. All of you ask me this question every day, that females with CH get ambiguous genitalia while males with CH get precocious puberty. Early puberty is precocious puberty. So females with CH get ambiguous genitalia and males with CH get precocious puberty, early puberty. Okay? Remember, before coming to the drug of choice, please remember a very important question. How do you diagnose CH? 17-hydroxyprogesterone. So remember, this test is now available all over the world in all the babies. 17-hydroxyprogesterone. Okay? Drug of choice is, you give steroid. So you give hydrocortisone. So drug of choice is hydrocortisone with normal saline bolus. सबसे पहली बात, drug of choice will be a normal saline bolus with hydrocortisone. Then you can also add a mineralocorticoid, fludrocortisone. So you can also add a mineralocorticoid, fludrocortisone. Okay, so that's the drug of choice, hydrocortisone. Now all of you should know this mnemonic. It will always help you in your life. Just write in your copies 21, 17, 11. Just write in your copies 21, 17, 11. और ऊपर लिखो M and T. M का मतलब है मिनरलोकॉर्टिकॉइड, T का मतलब है टेस्टोस्टेरोन. ओके, M मतलब मिनरलोकॉर्टिकॉइड, T मीन्स टेस्टोस्टेरोन. सो अब 1 को बना दो एरो. 1 को make it like an high, make it like this arrow. So it means, students, in 21 hydroxylase deficiency, testosterone is high, mineralocorticoid is not. In 17, mineralocorticoid is high, so there is hypertension in 17 and 11. So in 17, testosterone is not high, and 11, all of you from Punjab, जब ऐसे करते हैं 11, इसका मतलब both of them are high. So all of you, God made 11 beta hydroxylase deficiency has both hypertension and increased testosterone. So remember this mnemonic, all of you, 21, 17, 11. So please remember this mnemonic. Simple hai, 21, 17, 11. Okay, please remember this. Now a very important point before we go further. Every NEET-PG एक सवाल आना ही है, what is SAM? Every NEET-PG you will always get a question on what is SAM. So please 1 minute लगाएंगे इस पे. What is SAM? SAM is defined in 2 age groups, below 6 months and 6 to 59 months. It is defined in 2 age groups, below 6 months and 6 to 59 months. Okay? As any of the following, okay, any. And remember, SAM मतलब severe acute malnutrition. So आप लोग सब लोग जो टाइप कर रहे हैं, प्लीज लिखिए यहाँ पे चैट बॉक्स में. SAM is weight for height below -3 standard deviation. सब लोग बोलो मेरे साथ, SAM is weight for height below -3 standard deviation. So acute is weight for height below -3 standard deviation, or edema or mid-arm circumference below 11.5 centimeters. Okay, or edema or mid-arm circumference below 11.5 centimeters. Okay, in a child below 6 months we cannot use mid-arm circumference. So again, weight for height below -3 standard deviation is SAM. ओके, वेट फॉर हाइट. तो एक बार मैं आप सबके लिए फिर से बोलता हूं, सैम is weight for height less than -3 standard deviation. Acute malnutrition. So acute marker is weight for height. Chronic marker is height, you know height for age. Chronic का मतलब होता है stunting. So chronic is stunting. Okay, so please remember this. And undernutrition or underweight is a weight for age less than -2 standard deviation. So please remember, underweight, if they ask, it's a weight for age less than -2 standard deviation. Excellent. Everyone is very interactive today. Excellent. So what I'll do is I'll be also talking about that in your exam you will also get a question on important points about nephrotic syndrome. So guidelines have changed. Okay, guidelines have changed. So you should know that there are some new guidelines in 2021 on nephrotic syndrome. So you should know about the new guidelines of nephrotic syndrome. I'll just tell you few important points which you should know about nephrotic syndrome. Of course, in children, it's MCD, minimal chain disease in children, and the drug of choice is prednisolone. But remember, now nephrotic syndrome in children frequently relapses. They frequently relapse. So remember, the drug of choice for a frequent relapser, nephrotic syndrome, is now oral levamisole. So now this year we have changed the guidelines, and now it is clear the drug of choice for a frequent relapsing nephrotic syndrome is levamisole. Drug of choice for steroid dependent, a child who has got toxicity. So in your exam they may show you a child who has a lot of steroid toxicity, Cushingoid, hypertensive, cataract. For them we give oral cyclophosphamide. Okay. Now what is steroid resistance? What is steroid resistance? Now remember, now the new guidelines, students, remember, अब हमारे 2021 में, now we say no response to 6 weeks of steroids in children. No response to 6 weeks of 2 milligram per kg prednisolone. No response to 2 milligram per kg prednisolone in children is steroid resistance. Steroid resistance is mostly FSGS, focal segmental glomerulosclerosis. अब हम 6 weeks कहते हैं, हाँ जी, in children. And the drug of choice is calcineurin inhibitor called tacrolimus. So remember, the drug of choice for steroid resistant FSGS is tacrolimus. Okay, so remember, drug of choice for steroid resistant FSGS is tacrolimus. Okay, so remember that. Let's go further now. And now what we'll do is we'll be talking about whenever you have a child in your exam, if they show you a child with recurrent urine infections, you may have a case of recurrent urine infections. So please remember, what is recurrent urine infections? Basically more than two or more culture positive urine infections. But simple, हम यही कहते हैं, any child who gets 2 or more culture positive symptomatic UTIs. Okay, 2 or more culture positive UTIs. Remember, on your screen is the most common cause of UTI in children, जिसको कहते हैं VUR. The most common cause of UTI in children is vesico-ureteric reflux. मतलब ये बच्चा यूरिन पास कर रहा है and urine is refluxing to the upper system. Urine is refluxing to the upper system. Okay, that's called vesico-ureteric reflux. Okay. Okay. So remember, VUR is the most common cause of UTI in children. Most common cause of UTI in children is vesico-ureteric reflux. Okay. Remember, on your screen, the IOC, the investigation of choice, is MCU, which is also called VCUG, which is also called VCUG. मतलब हमने बच्चे के ब्लैडर में डाई भर दी using a Foley's catheter. Okay, so using a Foley's catheter, हमने बच्चे के ब्लैडर में डाई भर दी, and then we remove the Foley's, and when the child is passing the dye, he's about to pee, you can see this dye refluxing to the upper system. So this is a voiding film, a voiding cystourethropy, or a micturating film, or a micturating cystourethropy. Now remember, VUR leads to polar scars at the poles, upper pole and the lower pole. It leads to polar scars of the kidney, for which we do a DMSA nuclear scan. For which we do a DMSA nuclear scan. Okay? For which we do a DMSA nuclear scan. Okay? So please remember that. Remember, normally we don't go for surgery in VUR. हम नॉर्मली सर्जरी नहीं करते. ऑल ऑफ यू सर्जन्स आपको बोलेंगे हम तो सर्जरी कर देते हैं रीइम्प्लांटेशन. ऐसा नहीं है. We only do surgery which is called ureteric reimplantation if it is a bilateral high grade VUR, grade 3 or more VUR, or if this child has multiple UTIs, breakthrough UTIs. If he has breakthrough UTIs on prophylaxis, so basically हम इस बच्चे को एक छोटी सी एंटीबायोटिक शुरू कर देते हैं, oral cotrimoxazole. So we start him on oral cotrimoxazole. Okay, that's the drug of choice for prophylaxis, oral cotrimoxazole. And if he gets multiple UTIs on cotrimoxazole, we send the child to the surgeon for ureteric reimplantation. All of you, I have a quiz for you before we go any further to the journal important neonatal resuscitation. All of you, on your screen is a MCU, and this child has weak stream. This is a boy with weak stream. And can anyone in the class tell me what is this micturating film showing? This is a quiz for all of you. Anyone? This is a boy with weak stream, and on your screen is an MCU. Can anyone in the class tell me what is this MCU showing? And what is this on your screen? Can you see what is this on your screen? This is a valve, you're right. This is a valve in the posterior urethra. It's a posterior urethral valve, because of which this is a whole dilated urethra. The urethra is dilated urethra. Bladder is thick walled. So remember, again, MCU, these walls of posterior urethra are only seen on an MCU. Okay, so investigation of choice for valves is also an MCU. Okay, is also an MCU, and the treatment is cystoscopic fulguration. So remember, the treatment is cystoscopic fulguration. Okay, so using a cystoscope we fulgurate the valves. Okay, so using a cystoscope we fulgurate the valves. Now, I'll be talking about important emergencies. I'll be talking about important emergencies in children. Okay, I'll be talking about emergencies in children. And first of all, remember that foreign bodies are common in children. Remember, foreign bodies are very common in children. And the most common airway foreign body in children is nuts. किसी ने काजू खिला दिया बच्चे को, किसी ने बादाम खिला दिया बच्चे को, तो काजू खिला दिया, बादाम खिला दिया. So if you have a child who is responsive and he's choking, so what will you do? What are you doing on your screen? We are giving him 5 back blows and chest thrust. Okay, so remember for an infant, with a who is responsive and who has a foreign body, you give 5 back blows followed by chest thrust. Okay, while in older children, we give them the Heimlich maneuver. So for a child more than 1 year who got, suppose उसने fish bone खा लिया, fish bone गले में अटक गया, so we will go for a Heimlich abdominal thrust in an older child. Okay, so we will be talking about emergencies in this half, and all of you please remember that first of all in your exam the most important point you should know is neonatal resuscitation. So we'll first talk about the neonatal resuscitation. There's no doubt you will definitely get a question on neonatal resuscitation. So what is your first step when a child comes to you with a baby is born? What will be your first step? So remember, when a baby is born, your first step is to ask yourself 3 questions. क्या सवाल पूछने हैं आपको अपने आप से? Term, tone, crying. Term, tone, crying. Okay, so if he's breathing well, okay, okay, so then if he's term, everything is yes, so you can transfer him to his mother. Okay, and you know, TABC, look at the temperature, airway, breathing, circulation. Now this year in June, what will happen is in June this year the new guidelines of neonatal resuscitation will come. By that you will be PG by then, but remember, drying will come first now. Of course, you know, we should dry a baby first. So this will come as a new point this year in the NALS guidelines this year. Okay, now remember, if the answer is no, he is not term, okay, or he is not breathing, you will do TABC, and again the new guidelines will talk about drying first, dry the baby first. अब सबसे पहले देखना है breathing. If a baby is breathing, तो ठीक है, then you look at the heart rate. But suppose we did the normal steps, temperature, airway, we did the positioning, we suctioned the mouth followed by nose. एक word सुनो, mouth followed by nose, and this baby is not breathing. Now we'll start this baby on bag and mask ventilation or positive pressure ventilation. So all of you please remember, the first indication of positive pressure ventilation is baby is not breathing after the initial steps. Okay, or baby is gasping, or after the initial steps baby is breathing but heart rate is below 100, you will start positive pressure ventilation. And please all of you have a careful look here. जब भी positive pressure ventilation शुरू करते हैं, we start pulse oximetry, we consider ECG. So pulse oximetry is very important, students. I'll talk about this again. Pulse oximetry is very important. Okay, चलिए हमने bag and mask शुरू कर दिया. Now after 30 seconds, students, heart rate is still below 100. So can anyone in the class tell me what is the most important indicator of adequacy of ventilation? How will you know your ventilation is fine? Is it the increase in the heart rate or chest rise? Increase in the heart rate. So remember, the most important indicator of adequacy of ventilation is increase in the heart rate. Increase in the heart rate. Now heart rate is not increasing. I will look at the chest rise. Okay, if heart rate is not increasing, I will look at the chest rise. ठीक है, याद रखिएगा. Adequacy is okay by increase in the heart rate. Now, अब हमने क्या किया? If heart rate is below 60, now if heart rate is below 60, after 30 seconds of bag and mask ventilation, तो सबसे पहले हमने किया bag and mask ventilation. After 30 seconds of bag and mask ventilation, if heart rate is still below 60, we start chest compressions. And when you start chest compressions, please all of you ध्यान से सुनो, when you start chest compressions, you intubate, you give 100% oxygen. ये बात बहुत इंपॉर्टेंट है. देखिए, नॉर्मली वी डू नॉट गिव 100% ऑक्सीजन इन नियोनेटल रिससिटेशन. नॉर्मली इन अ बेबी लेस देन 35 वीकर we give 21 to 30%, and a baby more than 35 weeker, normally we use 21% oxygen. But when we do chest compressions, we always give 100% oxygen. Always give 100% oxygen. Okay, intubate, ECG. Okay, अब chest compression शुरू कर दी. And remember, our ratio is 3:1. 1 and 2 and 3, okay, 1 and 2 and 3 and squeeze. Okay, so 1 and 2 and 3 and squeeze, and 1 and 2 and 3 and squeeze, and so the ratio is 90:30. Okay, so ratio is 90:30. So 120 events in 1 minute. Okay, so when we do chest compressions, we do 90 chest compressions in 1 minute and 30 bag and mask ventilations in 1 minute. Okay, now lastly and the most important point, students, for your exam is, when do we give epinephrine? So remember, we give epinephrine if heart rate is below 60, despite 30 seconds of bag and mask and 1 minute of chest compression. तो chest compression 1 minute करेंगे, फिर देखेंगे. So despite 30 seconds of PPV and 1 minute of chest compression, if heart rate is still below 60, I will give him epinephrine. Okay, and what is the dose of epinephrine? You cannot pass without this must know point. The dose of epinephrine, students, the dose of epinephrine is 0.1 to 0.3 ml per kg of 1 in 10,000 dilution. Dose of epinephrine is 0.1 to 0.3 ml per kg of 1 in 10,000 dilution, which becomes equal to 0.01 to 0.03 milligram per kg. So they can ask you in milligram per kg. So it becomes equal to 0.01 to 0.03 milligram per kg. This is the intravenous dose. Now if they ask you the endotracheal dose, remember the endotracheal dose of epinephrine is 10 times the usual dose. So we still give 1 in 10,000 dilution, and we give 0.5 to 1 ml per kg of the endotracheal dose. So same वैसे ही देना है, but we give 0.5 to 1 ml per kg. This is 10 times the usual dose of epinephrine. And students, what is new in our guidelines is that now we always do pulse oximetry. जब भी कोई बच्चा पैदा होगा, he required some resuscitation, consider pulse oximetry. Put a pulse ox on the right upper limb. Put a pulse oximeter on the right upper limb. Right upper limb is preductal. This question is a favorite of your examiners. Remember, right upper limb is before the ductus arteriosus. It is preductal. तो जब भी कोई बच्चा पैदा होता है, ठीक नहीं होता, कुछ प्रॉब्लम है, we put a pulse oximeter on his right upper limb. It is before the ductus. Right subclavian is always before the joining of ductus to the aorta. It's always preductal. So put a pulse ox on the right upper limb and put a pulse ox on the lower limb. We'll look at, the difference between the saturations of the upper limb and the lower limb. So remember, we have some targets. Your NEET-PG examiners love to ask these targets. So the target pre-ductal right upper limb saturation at birth at 1 minute is 60 to 65%. At 2 minutes, 65 to 70%. 3 minutes, 70 to 75%. तो लास्ट नीट पीजी में आया था 3 मिनट्स. सो ये याद रखना पड़ेगा. ऑफ कोर्स यू हैव टू रिमेंबर दिस बिफोर यू गो टू द एग्जाम. प्लीज रीड दिस. 1 minute 60 to 65%, 2 minutes 65 to 70%, okay, 3 minutes 70 to 75%, okay, 4 minutes 75 to 80%, 5 minutes 80 to 85%, and almost 10 मिनट पे जाके आती है नॉर्मल सैचुरेशन 85 to 95%. So almost at 10 minutes जाके we get the normal saturation which is 85 to 95%. Okay, so please remember that you cannot pass without this. Okay, so you need to know this. Now before going to the next topic, this is the most important topic again. RDS, you know, your examiner is a neonatologist. Okay, and in fact the person who is making the COVID guidelines of the country, the head of Niti Aayog, is a neonatologist. He loves talking about prematurity. Okay, he is now, you know, taking care of our country now. The ex head of department of All India Institute. So they always will have a question on RDS. Remember, all of you should know that surfactant is mostly saturated phosphatidylcholine. Okay, surfactant is phosphatidylcholine. Okay, followed by unsaturated phosphatidylcholine. So mostly it's phosphatidylcholine. RDS is deficiency of surfactant, common in preterms. So RDS is deficiency of surfactant, common in preterms. So risk in babies less than 28 weeks is very high, almost 60 to 80%. So risk is very high in these babies who are at risk less than 28 weeks. Okay, so remember, all of you, that you need to know that now the new Nelson's textbook, हमारा neonatology का heart क्या है? Nasal CPAP. So now all the guidelines, OP Ghai, the Nelson's textbook, all guidelines say that we should give prophylactic CPAP to at-risk babies in the delivery room. So now the guidelines say we should give prophylactic CPAP. बच्चे को डिस्ट्रेस भी नहीं हुआ. Even before that, okay, even before that, you should start prophylactic CPAP in the delivery room. It has been shown that, you know, it prevents the complications. Now remember, last year the new AIMS NICU protocols came. AIMS NICU protocols. So they say every preterm, if he gets distress, your first step is nasal CPAP. So please remember, every preterm who gets distress, you need to give nasal CPAP. अब simple है, it is clear now. ऐसा कुछ नहीं है कि पहले surfactant देना है, ऐसा बिल्कुल नहीं है. Every preterm with distress, first give nasal CPAP. Okay? And अगर CPAP पे बच्चा ठीक नहीं है, he is requiring increased PEEP, he is requiring increased, you know, end expiratory pressure. Okay? No, every preterm below 37 weeks, okay, you have to give him nasal CPAP first. So that's important. If he fails the CPAP, he's requiring more oxygen, he's requiring more PEEP, then you have to give early rescue with insure within 2 hours. So remember, it has been seen, अगर बच्चा ठीक नहीं है तो 2 घंटे के अंदर you have to give him intratracheal surfactant. Intratracheal surfactant. Intubate, give surfactant, and as soon as possible extubate. So जो भी करना है 2 घंटे में, you have to decide. CPAP, if he's doing okay, fine. But if he is not doing okay on CPAP, he is requiring a lot of PEEP, a peak end expiratory pressure. Okay? Okay? Or if he is requiring, lot of oxygen, you have to give him more oxygen. Okay? Okay, so you should go for intratracheal surfactant. So remember that, that's very important. Okay, all of you? Yes, so everyone, for every preterm with distress, first of all, you have to give him, CPAP first. So that's the most important point. And before going further, I would just like to show you 2 important pedigrees which are important for your exam, and then we'll stop for the day. Every exam of yours seems to have a question on mitochondrial inheritance. Just remember माँ को याद रखो, माँ. Maternal inheritance is mitochondrial. Mother, if mother gets affected, all children are affected, it is mitochondrial. All children of affected mother are affected, it's mitochondrial. Okay? So remember, mitochondrial inheritance is MA. Okay? And the examples are Leber's hereditary optic neuropathy. Okay? MERRF, myoclonic epilepsy and ragged red fibers. Myoclonic epilepsy and ragged red fibers. MELAS is mitochondrial encephalopathy, lactic acidosis and stroke-like episodes. Okay, mitochondrial encephalopathy, lactic acidosis and stroke-like episodes. NARP syndrome, neuropathy, ataxia and retinitis pigmentosa. Pearson syndrome is mitochondrial. Leigh disease, LEIGH, Leigh disease is mitochondrial. And lastly, deafness, which is because of aminoglycosides, is also mitochondrial. Deafness because of aminoglycosides is also mitochondrial. Okay? Okay, so remember that. Now, the very important, the last topic of the day, I know your anatomy sir is waiting, so I will just now take you to the last pedigree of the day, which is called genomic imprinting. Now, what is genomic imprinting? It basically means that the expression depends on the parent of origin of defect. The expression of a genetic defect depends on the parent of origin of the genetic defect. Okay, expression depends on the parent. On your screen, when a child got the deletion from the ma, only then he manifests. Can you see? Whenever mother gives, बच्चे बीमार हो रहे हैं. But when a father is giving the disease, children only become carriers. यहाँ पे बच्चे सिर्फ तभी बीमार हो रहे हैं. They are only, children are only manifesting when they get it from their ma. So expression depends on the mother here. So on your screen is a pedigree of Angelman syndrome. On your screen is a pedigree of Angelman syndrome. Okay? So remember, genomic imprinting means the expression depends on the parent of origin of the defect. And remember, 70% of Prader-Willi syndrome, 70% of Prader-Willi syndrome is because of deletion from the PA. Deletion of the chromosome number 15, Q11 to 13 deletion. 70% of Angelman syndrome, 70% of Angelman syndrome is deletion from the MA. 70% of Angelman syndrome is you get the same deletion from the MA. Okay? Now please, all of you, your examiners always, one of your examiners, she's a pediatrician and the head of genetics at All India Institute. She likes to ask about genomic imprinting. So you should know about Beckwith-Wiedemann syndrome is genomic imprinting. The inheritance is genomic imprinting. Okay? Russell-Silver is genomic imprinting. Okay? Temple syndrome, Wang syndrome, Wang, W-A-N-G, Wang. Transient neonatal diabetes mellitus. Transient neonatal diabetes mellitus. Transient neonatal diabetes mellitus. And lastly, pseudo hypoparathyroid 1b. Pseudo hypoparathyroid 1b. Okay, the inheritance of that is also, so these are 8 known imprinting disorders. 1, 2, 3, 4, 5, 6, 7, 8. So these are 8 known imprinting disorders. Okay, and we have a student asking us about, sir, can you tell what happens to the remaining Prader-Willi and Angelman? So remember, we have a student here, Dr. Mona, especially for Dr. Mona. Remember, uniparental disomy. Uniparental disomy. Remember, 30% of Prader-Willi is unimaternal disomy. तो जब हम डाइजोमी की बात बोलते हैं तो उल्टा बोलते हैं. So 30% of Prader-Willi is unimaternal disomy. Okay? Okay, remember that. And what about Angelman? अब हम उल्टा बोलेंगे. 5% of Angelman is unipaternal disomy of the same defect. Unipaternal disomy. So please read that. So 5% of Angelman is unipaternal disomy. Okay, so please remember that. And all of you, before I close for the day, I would like to tell you guys that whatever you want to become in your life, follow that. Don't change ki bhai acha don't compromise in your life. I'll tell you about myself, students. I am a pediatrician, but then I went into doing more of pediatric nephrology. I take care of children who have kidney disease and kidney transplantation, and I am a pediatric nephrologist. I'm the head of pediatric nephrology at a hospital here in North India, and my department is here on the 12th floor, and since last 10 years we only look after children with kidney disorders. So what I'm trying to tell you is that actually I always wanted to be a pediatrician. I never thought about in my life that कि मैं कुछ और बनूंगा. And I always thought about that, and whatever I used to do, my all actions were driven towards becoming a pediatrician. And here I am in front of you. I would say, life and how should you read? I think it's all about following your passion. If you follow your passion, definitely that will definitely come to you. Your branch will definitely come to you. Okay, वो कहीं नहीं जाएगी. She will definitely come to you. I mean your branch. Okay, so if you do well, you will definitely do well if you follow your branch. And I'm sure someday we, the faculty of DAMS, will be enjoying a drink with you on the other side of the table. And on behalf of the DAMS family, I wish you all the best, and we are always there solving your doubts, and we are always there online any time of the day or night. And All the best. I'll see you on the other side soon.